Hello, Wayne County Community College students. Let's go on and finish up with, we're still in chapter 27, so we're looking at blood, and we're going to start with blood typing today. So here you see we have type A, type B, type AB, which is the universal recipient, and we have type O, which is the universal donor. This is the ABO group of blood typing. So type AB, the universal recipient, means that this person that has type AB blood can receive blood from type A. This person can receive blood from type B. And of course, since type O is the universal donor, type AB can receive blood from type O. Of course, type O is the universal donor, so type O can donate to type A, type B, type AB, and of course, the type O. Actually, the only blood that type O can get is type O. If type O person gets blood from a type A, they're going to have antibodies on it and attack that type A blood. If type O gets blood from type B person, they're going to have antibodies, anti-B antibodies on the blood, and type O will attack that person's blood. If he gets any blood from a type AB person, type O is going to attack that person's blood. But otherwise, this type AB can receive, the recipient is the receiver, can receive blood from everyone. Type O, the universal donor who gives blood to people, can give blood to everyone. Okay? So those are the things we're going to talk about first. Now, some of you may be saying, well, I'm type A positive or A negative, or I'm type B positive or B negative, or type AB positive or AB negative, or type O positive or O negative. Well, we're going to talk about what makes the blood negative and positive in a minute. But first, let's just look at compatibility of type AB and ABO blood types, okay? Let's look at the compatibility. Here I have drawn a sketch of the donor over here. These would be all the donors. You can see the line going this way. So that shows that this type on the far left will be donating to the person on the right side. That will be the recipient. And then we have the word agglutination, which is a real kind of loose term for clot. And then no agglutination, which would mean no clot. That's just loose terms. If we get clotting in any of these, that is not a good match. You do not want your blood to clot when you're getting transfused, right? If we have no agglutination, then okay, that person can be transfused, we're saying, with no problem, no complications. So let's keep this, what we just went over, in mind as we see this donor, type O, is going to donate to type AB. We know that type O is what? Yes, the universal donor. So type O can go to anybody. So anytime you see type O as the donor and anybody is the recipient, type O can give to them. So type O wants to give blood to type AB. Would you say that the blood will clot, meaning that shows a rejection? Or would you show agglutination? Or would you show no agglutination, no clot, which means that the blood is just fine to be received by this recipient? Correct. Type O can easily donate to a type AB person. No agglutination. So we will check that column. Type AB, however, wants to donate to type B. Type AB wants to donate to type B. Let's look at that. So this B here in the recipient column says, oh, I recognize B. Okay, that's cool. You can come on over. I can handle that. But then who is this? What is that? That's an A. This B has anti-A antibodies all on it. When AB blood comes to donate to a type B anti-A antibodies are like, oh heck no, don't bring an A over here. I can't handle that. I recognize the B, sure thing, but not that A. So I will have a problem. So that blood will clot. So that'll be agglutination. Type B has anti-A antibodies, correct? And type A has anti-B antibodies. So type B trying to donate to a type A person, that will be a clot for sure. Type B wants to donate to type AB. Well, this B in the recipient recognizes this B over here. So that B can come on over. It's fine. It's AB. B is not bringing anything else over. Nothing foreign is coming over with it. So B recognizes B. I know that that's an AB, but it can accept that B because the B isn't bringing anything else with it. So that is no clot, no agglutination. Type O wants to donate to a type O recipient. Fine. This donor can donate blood to a type O. Of course, likes can accept likes. So no agglutination. Type AB wants to donate to type O. What do you think? Can type AB donate to type O? No. Type O can only take type O. So that would be an agglutination there. Type A wants to donate to type AB. Well, let's see. This A here with the recipient recognizes this A from the donor. That A can come on over. This A isn't bringing anything else, so that's fine. So that'll be no clot. Type O is the universal donor, wants to donate to type B. That's perfectly fine, no agglutination. Type A wants to donate to type B. Did I do that before? No. Type A wants to donate to type B. You know that's a big problem, so that's going to be a clot, agglutination. And type AB wants to donate to type AB. Likes can always go to likes, so AB can always go to AB. B can go to B, A can go to A, O can go to O, etc. So this will be no clot, all right? So that is the big scheme of things, and that's really the easiest way for me to kind of show you about donor and recipient and blood types. Just remember, if a type A or type B wants to donate to AB, that is fine. But an AB donating to a type B or an AB donating to a type A, that will not be fine. So let me write another one up here. Type AB donating to a type A. What do you think? Well, we see that this A here with the recipient will recognize this A with the donor, but the recipient will not recognize this B. You can't bring that over because the type A has anti-B antibodies on it, so it will attack that B. So this will be a big old clot, right? So make sure you understand that concept when you are going through your studies. Now, we said we were going to talk about the O positive and O negative. So, or let me just say not O positive, O negative, but all of these blood types as positive and negatives. And let's just start off with where that concept came from. So here we have something called rhesus factor, and this RH comes from rhesus, really named from some rhesus monkeys that some scientists noticed that these monkeys were not producing or something, having stillborn monkeys, and he wanted to know why was this happening. It's like in the 50s, and he also had contributed this idea to what's going on even with mothers that were having these spontaneous miscarriages or spontaneous abortions and having these miscarriages. So let's go on and find out what was happening. And this was just a brilliant concept. So this comes from the rhesus monkey. Because back in the day, we used to do experiments on animals. We don't do that anymore, but we used to be able to. So rhesus, so RH factor comes from, you can have a RH negative, so I'll put negative. Or you could have RH positive. RH positive. Now in this country, in the United States, about 85% of the people are RH positive. So like for me, I'm O positive. So I have an RH factor, so I'm positive for having RH. 15% of people in our country, the United States, are RH negative, meaning they do not have an RH factor. Now, it doesn't mean that something's abnormal or something's wrong with the person that doesn't have the RH factor, or something's wrong with the person that does have the RH factor. It just means that this is a normal variance, and just like some people have brown eyes and some people have hazel eyes. There's nothing wrong with the colored eyes, they're just different. So this is what the deal is, but the majority of people in the United States have a RH positive. They have the RH factor, in other words. Only 15%, but each author would say whatever percent, but that's not the main thing. I just want you to get the gist that most people do have the RH factor. The problem comes in is when the mom, the potential mom, say she's pregnant, potential mom is RH negative. So we're going to say RH negative. This is a potential mom, but she's pregnant. So RH negative mom. Why is that a problem? Only because most people are RH positive. So say she's having her first child. So we say first pregnancy. First pregnancy. 9 times, well, not 9 times out of 10, because that would be 90%. We'll just say about 85%, that child is going to be RH positive. So first pregnancy, the child is RH positive, okay? Now, I need you to understand that blood from the fetus does not generally mix with the mom's blood. Just in general. It's not like the fetus is getting transfused from the mom's blood and just getting that mom's blood to make its own. No, the fetus makes its own blood, starting with the yolk sac, then eventually get some bone marrow, and they make their own blood. The blood from the mom and the fetus does not mix. Now, during a pregnancy though, during the delivery coming from the birth canal, say, for example, in our country, it's kind of traumatic. It's a lot of cutting, and it's just, they make it like over the top. And so sometimes they may do an episiotomy where they cut from like the vagina to near where the anus is to try to help make the passageway a little wider, which that's controversial, doesn't really help, some people say. So that's up in the air. But the point is that now you got a lot of blood. And when the first delivery, this is her first pregnancy, first delivery, I should say, sometimes when they cut the cord, for example, some of the cord blood could mix with the mom's blood. So let's just say it was a traumatic birth and somehow the baby's blood mixed with the mom's blood. And usually the baby's blood is coming from the cord because the baby's not bleeding anywhere else. So we'll just say that somehow it mixed. Now, so more than likely that child is RH positive. Why? Because most people are RH positive in this country. So that RH positive is going to mix or be introduced into the mom's bloodstream. Now the mom is RH negative. That RH negative is going to see that RH positive as an enemy. So it's going to build antibodies against it, and now it's going to have antibodies. This mom is going to have antibodies in her blood to protect her from this RH positive factor. And that's fine. The first baby is born, it's out of the the womb and that baby is fine. The problem comes in with subsequent pregnancies, second, third, fourth, fifth, etc. How many other pregnancies? Just say second pregnancy comes. So second pregnancy. And let's just say because most other people are Rh positive, we'll say that baby too is Rh positive. Now, when you are an obstetrician or OBGYN, obstetrician, gynecologist, and you get an Rh negative mom, it is your duty to make sure that mother is treated with a protein known as, they got many names for it, but the one I'm most familiar with is RhoGAM. RhoGAM will help prevent the mom's body from forming anti-Rh antibodies. So this protein will help the mom not form antibodies against Rh positive pregnancies. Why is this so important? Because if the mom is not treated, this Rh negative mom is not treated, and she has her second pregnancy, because now remember, with the first pregnancy, it was some mishap, some blood got mixed with the mom, and now the mom has formed antibodies. So when that mom's blood sees Rh positive anywhere, that blood is going to, the antibodies are going to attack it. So the second pregnancy, this baby could be in trouble. And if that doctor did not protect this mom or protect that baby by giving the mom RhoGAM, then this fetus's blood can shear. And we call that, let me just put that RhoGAM up here. And we call that erythroblastosis fetalis, also known as hemolytic anemia of the newborn. That's a more modern term, but erythroblastosis fetalis was the way I learned it. So usually you see this is a fetus, and erythro are red blood cells. Blastocytes are real infantile or very immature cells. So that kind of tells you what's going on. And then hemolytic, this means like the blood is lysed, it's lytic, it is kind of ripped apart, anemia of the newborn. This is, remember how red blood cells look nice and plump, and of course, like that. Well, if this mom is not protected with RhoGAM, the baby's red blood cells look like this. Now, that's not a good red blood cell. You can't carry any hemoglobin on these things. You can't carry any oxygen on these things. You need blood that looks like this. But that's what happens. When the mom is not protected, the Rh negative mom is not protected with RhoGAM or something like RhoGAM, the baby's blood starts to look like it went through a paper shredder, or like, you had some glass and you just threw it down on some ceramic tile. That's the way the blood looks. And that's gonna be pretty detrimental to that fetus. So this is why it's important to get RhoGAM. And I mean, an Rh negative mom needs to be treated with this protein, for every pregnancy. I don't care if she elects to abort that fetus, if she is going to have the fetus carried to term and give it up for adoption, if she just has a spontaneous abortion or a miscarriage. I don't care what happens. If she gets pregnant, an Rh negative mom, she should still be treated with RhoGAM. Just make that perfectly clear. I don't care what she does with it. I said if she gets pregnant. I don't care if she takes the morning after pill. she needs to be treated with Rogaine. Is that understood? So any subsequent pregnancy will not have the fetus in danger of erythroblastosis fetalis, also known as hemolytic anemia of the newborn. Now, suppose she has a third pregnancy, and that baby is Rh negative. She still needs to be treated with Rogaine. Why? Because we don't know that fetus's blood type. We're not going in, we're not taking any amniotic fluid, we're not doing an amniocentesis to find out. So she still needs to be treated. Although she will not have antibodies to an Rh negative pregnancy fetus, because she is Rh negative, and so is the fetus. But we don't know what the fetus is. So we do know what the mom is, and we know if she's Rh negative, she needs to be treated with Rogaine. Okay? So the father really doesn't have much to do with this part. He already showed up, if you know what I mean. So we just need to concern ourselves with the mom and the pregnancies. And that will, be the big deal. So this is how you can become Rh positive. This is how you become A positive or A negative. B positive or B negative. I hope you will be positive, if you know what I mean, not B negative, but that's a joke. AB positive or AB negative. O positive or O negative, okay? So this is what this means, and we're gonna, that's what this means, and then we'll get back with we'll talk about some clotting next. Okay, so let's go on and talk about clots, also known as thrombus or thrombi. So let's look at, we're near the end of the chapter now, and this will conclude chapter 27. So let's look at prothrombin. Prothrombin to thrombin. For prothrombin to thrombin, it uses a prothrombin activator. Prothrombin activator and calcium. So prothrombin, to go from prothrombin, which by the way is inactive, it's a big old clunky inactive molecule that needs to be cleaved. It needs to be cleaved, so it's cleaved here by using prothrombin activator and calcium to become a nice sleek molecule that's active, and that's known as thrombin. So this is just always in our system, in our blood system, prothrombin, but usually it's inactive until you need to get a clot. And of course, clots are good when you get cut or some kind of wound. It helps so that you don't bleed to death. So prothrombin is inactive. It uses prothrombin activator and calcium to become thrombin, which is active. Why do we need that? Because fibrinogen is going to have to utilize thrombin here. So we'll say thrombin comes here, and also calcium to make fiber. Here's fibrinogen, another big clunky molecule that's inactive. It needs to be cleaved to become nice, sleek, vibrant. So there's an entire cascade involved in making a clot. Intrinsic, extrinsic factors to make a clot, other factors, factor 8, hemolytic factors, etc. But we're not going to discuss all of those factors, and we're not going to discuss that entire cascade. These things are the main things I need you to understand about making a clot: prothrombin is inactive. It utilizes prothrombin activator and calcium to become the active form, which is thrombin, which in turn, thrombin is used to cleave fibrinogen, which is an inactive form, and calcium, along with thrombin, to make an active form of fibrinogen known as fibrin. What's the big deal with fibrin? Well, fibrin is, it looks like fibers actually, like thread. And I'll just draw it like this. It looks like a mesh, or you could call it like a fisherman's net. I guess you could think of it like that. And what it does is it captures red blood cells and it also captures platelets. So I'll just put the little platelets around like that. And now you have formed a clot. And that's a good thing. If you're like in the book, the guy stepped on a nail, penetrated his foot, he's bleeding. Well, you don't want to keep bleeding, of course, so the clot is helpful in preventing any more blood. So these 4 components, I'll just write these out. These are the 4 components I want you to be familiar with in making a clot. And you can also go through your text and look at the entire cascade of the intrinsic and extrinsic factors involved. And then you can get more ideas and appreciation. But this, for our purposes, these are the main things that I are interested in you knowing. Okay? So with the 4 components, prothrombin, thrombin, fibrinogen, and fibrin. Do you guys remember when you first saw fibrinogen? Do you remember when we learned about plasma and we talked about albumin, globulin, and then fibrinogen? You should remember that. That was just from last week. Here it is here, involved in clot making, and we see it right there, right? So that's important. Now, let's talk about clots when they're not so good. Overall, we know clots are good because they prevent you from bleeding to death. But then there are some clots you're like, maybe I would like not to have those. So let's look at the heart. And of course, the heart does not really look like that. And we will be learning about that next time. But we'll just draw the heart like this for now. And I'm going to draw some arteries in the heart. Oops. Arteries in the heart like this. And I'm going to put a clot. That little ball right there, that little circle, that's a clot. Blood cannot flow. Whenever there's a cessation or a stoppage of blood flow, there's going to be pain. This particular clot in that artery in the heart has caused blood to stop flowing to certain areas of the muscle of the heart. So this will be called a myo for muscle, cardio for heart, infarction for lack of blood, We also call that an MI, right? That's an MI. And I'll just say in other words too. For layman's terms, this is called a heart attack. Heart attack. So a clot in the blood, not a good thing. That's a myo meaning the muscle, cardio meaning the heart itself. Muscle is not being fed the blood, so that muscle dies in a myocardial infarction. All right, also known as an MI. Another one is in this organ. Let me just see if I can draw this organ here. Let's put blood vessels here. Like that. And I'll put a clot here. This is the brain. So we'll put a clot here in the brain. This is known as a cerebral vascular accident. Okay? Cerebral vascular accident, or CVA. That, in layman's terms, is known as a stroke. So a clot in the brain where the brain cannot get enough nutrients, meaning oxygen and other nutrients that it needs, that causes a problem, and you can visualize a stroke, usually slurring of speech, distortion of the face sometimes, or even paralysis on usually half of the body. So if the stroke is occurring on the right side of the brain, then it's an ipsilateral, meaning the left side of the body will be numb. If it's on the stroke is occurring on the left side of the brain, then the right side will be affected. Okay, it's the way the nerves are in the brain, how they cross, or the commissures. So here's the heart, the brain. Okay, here's another one, and I'm going to see if I can draw some toes here, a calf right here. Let's draw some arteries here, like here. I'll put a clot here in the leg. This is known as a deep venous, this is in the vein, not the artery now, thrombosis. Also known as a DVT, right? All right, so you get these, some people get these after long trips, if you don't get out and move and shake your legs. I know a person that drove from Detroit to Alabama for a family reunion, and the driver stopped for gas, I think about 3 times, but the passenger had worked all day and decided to just sleep and didn't get out of the car one time, didn't stretch the legs or anything, or even go to the bathroom. So they went straight down to Alabama, and when they came back, she and I were going to get a pedicure, and the pedicurist was doing her foot, and she said, it looks like your feet are swollen. She said, yeah, I noticed that. I had a hard time putting on my shoes this morning. And so I looked over, and her leg was swollen. Not just the feet, not just the foot, it was the leg too. I was like, She said, well, I just got back from a trip, and, I probably retaining water or something. I was thinking, one foot, one leg, I don't know about that. So we ended up, I convinced her to go to the ER, and they did a scan, I think it was a Doppler scan, where it's like an ultrasound, and they did find that she did have a clot. And that was because I later found out that she was pretty dehydrated. She just sat in the car the whole trip, did not get out and exercise. She didn't move her legs or anything. So that, she ended up being heparinized. They give you something to thin your blood to make sure that you don't, that you don't make any more clots. And it ended up being okay. But this is what can happen from DVT. And we see these a lot too now with children. Kids are sitting around and they're just playing video games like all night. And as long as the parents are like, "Ooh, at least they're not bothering me. I don't care if they stay in that room and play video games." But now children are getting DVTs from not moving enough. They're just on the computer or on these games for hours and hours and hours, and they aren't moving. So this can be a problem. Interestingly, this clot can travel, and a traveling clot goes to, let me draw some vessels here. So this is the lung, and another name for lung is pulmonary, right? So a traveling clot is an embolus, and this clot traveled straight there to the lung, and that makes this a pulmonary embolism. Or we call it a PE, right? This can cause a problem. Shortness of breath, difficulty breathing, and of course it can cause death. So this traveling clot, this traveling thrombus, when it's an embolus, That's what can happen. It can go to the lung. So that is it. Oh, so let me tell you some risk factors for getting a DVT. So risk factors for getting a DVT is you had a DVT before. So let's say previous DVT. If you had one before and you start having some shortness of breath, don't think it's anything else. Take yourself to emergency or have somebody take you to emergency and tell them, I have a history of DVT. You need to check my lungs and make sure I don't have clots in them. You need to heparinize me, make sure that my blood gets a little thinner so that I can breathe. Don't leave until they check you thoroughly. Previous DVT sets you up for another DVT. Pregnancy, big time for hypercoagulation. Pregnancy, hypercoagulation causes clots. How about this? Birth control. And I think not all birth control, of course, but usually oral contraceptives, they cause a lot of clots. They have a history of causing clots. Smoking, of course, smoking, I don't care what you're smoking. You could try to say, well, I smoke weed, and that's not doing anything. That's not true. First of all, smoking is not good for you. Secondly of all, you can't justify smoking. I don't care if it is weed. Weed is taking away your neurons, what's taking away your blood cells. And that's probably why you don't think it's doing anything. Because your brain cells are leaving. It's just falling out of your head little by little. Every time you hit a joint, your brain cells are leaving. So that's probably why you don't think there's anything wrong. But smoking can set you up for DVT. Sedentary lifestyle. Just sitting around, not exercising, not moving, DVT. Obesity, right? Real heavy, you're not moving, so that can set you up for DVT. Being old, elderly, mainly because the elderly, A, they don't drink enough water, B, they don't move enough, and C, usually they're more in the obese range. So that's a lot of factors that can set one up for DVT. These are the kinds of clots that are thrombi that we don't want, right? These first two are basically lifestyle related. Smoking, drinking alcohol, and eating fatty foods and fast foods, for example. These two can be prevented just through lifestyle changes. DVT, you gotta move. Simple. The human body is made to move, so move it. A walk. Just commit to taking a walk around the block, around the school track. Move. And that will help prevent DVTs. And whenever you travel, maybe even on the airplane, I would wear compression socks and I would stand up in the aisles. Maybe you're traveling, like going overseas or something like that. Get up and stretch your legs. Don't just go over that whole 7-8 hour flight. Even if you're going from here to California, I still get up and stretch in the aisleway. And I wear compression socks. So do not just sit. That's what I'm saying. They call them Ted hose, compression socks, whatever. Okay? So I think that will conclude chapter 27. You can read some other things in there. They have some good things in there on different diseases with blood. I'm not going to get into that. That's for patho. But I mention them sometimes. But for right now, we'll just stick with this. And on our next video, it'll be fun because we'll get to see the cardiovascular system. We're going to talk about the heart. So stay tuned.